What are the common issues for these two countries? The common reasons for fasting for diabetes are the Ramadan is the marker of cultural and religious identification. It's senses of being part of a group. It's a period of sharing with others, not feeling different from other peoples. And diabetes is not a serious enough disease to do not Ramadan. And the common points for Algeria and Morocco, it's the high prevalence of diabetes, more than 10% in Morocco and more than 14% in Morocco. We have gastronomic habits and nutriments during Ramadan. It's almost similar for the two countries with a high contains of sugar, for fat, for cholesterol, and also we have a healthy meal during Ramadan, a proposal for Dar Safa, for proposal with this platform for Dar Safa of Dar Alliance, Ramadan and diabetes in finalization. Many studies in Maghreb were published for diabetes and Ramadan, and the majority of this study focused in the fast or to fast, the choice of fast or to fast for Ramadan, for the change in food consumption, the Ramadan and induction, and the very factors influences Ramadan and fasting on Ramadan, the kidney disease and Ramadan, and the choice of medication. The main result or finding of this study in Maghreb, finding it's the difference is calories intake, the need for nutrition education for diabetic patients, more food high in fat and cholesterol, imbalanced glycemic and lipid profile, the risk of developing acute renal failure was significantly increased if the DFI is under 60 milliliter per minute, and empirically practicing for OADs, also sulfonylurea treatment for some years for the practitioner. This is the main problem we have in Maghreb with this publication in the last decade. In Algeria, we have conducted in this study for more than 900 patients, and we have more than 90% of type 2 diabetes who fasted. More than 50% of fasting patients are at high and very high risk. We are the imbalance during Ramadan with this glycemia. 30% of patients have hypoglycemia. We have the reduction of self-monitoring blood glucose, and about 20% of hospitalization because hyperglycemia, infection, hypoglycemia, dehydration, and diabetic foot. And the most problem we have is the insufficient of education. So we move for this reason for the Ramadan educational program from Dar Alliance. We've managed for many countries, including Morocco and Algeria in 2019. And like you see in this table, we have more than 900 of GPs who have this trainer with training with more than 2,800 patients. We have this training. This is two in Morocco, and this program have focused for education level and education during Ramadan. And we want to evaluate this program if this program in 2021. So we have a new trial with more than 1,600 inclusion for this for the last year, and we want to know the impact of pre-Ramadan education and train the trainer regarding the IDF DAR guidelines in practice in real life in our population. Like you see here, the percentage of the population who are included in this trial. We have 50% in low risk, 20% in moderate risk, and 30% with high risk. The first finding is the practice of our GPs and specialists. And look at these numbers. You have more patients are permitted when you have a low risk, and low patients are permitted to fast when you have a high risk for a moderate risk for diabetes. And I think regarding the DAR and the IDF, this is a very, very comfortable position for from our practitioner and GPs. If you look now to the patient, we have asked the patient which are not allowed to fast, and we ask them before Ramadan if they will fast, they will not fast, or they don't know if they fast or not fast during Ramadan. Look at the percentage of the number of this population from 574. 400 said that I will fast, 124 said that I will not fast, and 35% don't know. After Ramadan, we ask them if they are fasting or not, and we are this result. 48% have fasted, and 51% did not fast. We have an advantage in this trial that we have a change of decision from the patient. We have more patients not fasting, and we have less patients fasted from the patients which are not permitted to fast. It is a good point for education pre-Ramadan. And when you compare the number of days for population permitted to fast and population not permitted, we have 22 days for the population which are permitted, and 27 days with population not permitted. And the problem outcomes for the population with higher risk, 58% of problem versus 21% for population allowed to fast. What are the various points? The various points, it's in EPDR, 28 days in Algeria for type 2 diabetes, and the difference between countries for fasting, particularly for type 1 diabetes, which varied from 9.4% in Morocco to 71.6% in Arabia, Saudi. The other publication in 300 population from Morocco show that overall 64% of patients has fasted on the intermonth, whether 22 of the sample did not fast and 15 fasted partially. Factor influencing the number of days fasted during Ramadan is the presence of complication in Morocco. Another publication, a big publication, is the Dar 2020, this finding is the decision to fast during Ramadan vary widely among the countries, ranging from the lowest in Morocco and highest in Arabia, Saudi. Why this disparity? I think you know all these consensus and these guidelines from diabetes and Ramadan. And if you not forget this consensus of Casablanca in 1995, we have the criteria against fasting, type 1 diabetes, and more complication. And I think this suggests to not fasting for people with type 2 diabetes, type 1 diabetes, and some of type 2 diabetes. In conclusion, you can see that opinions are largely common from the two countries. Ramadan remains an important pillar requiring an educational approach adapted to needs and evolution of therapeutic and recommendation. As a result, there is a significant increase in the practice of fasting during this last decade, a substantial improvement in practitioners' pre-Ramadan education, which had a positive impact on patient behavior during Ramadan. And thank you for your attention.